Welcome back to the deep dive. Today we are really getting into a specific set of revision notes focused on one condition, infectious mononucleosis.
Mm,
You probably know it better as mono, or maybe, the kissing disease.
that's the one.
So our mission here is to take this stack of source material, these notes, and pull out the absolute highest yield stuff for your revision.
Yeah, let's boil it down.
We're told right up front it's caused by the Epstein-Barr virus, EBV. And it comes with those classic symptoms: fever, sore throat, swollen lymph nodes, and just feeling completely, utterly wiped out, that fatigue and malaise.
Definitely. Hits you hard.
Okay, ready. Let's unpack your notes and figure out what's most important to really get a handle on.
Right. So the notes, they start with the core definition, which is pretty direct.
Mhm.
Infectious mononucleosis is caused by the Epstein-Barr virus, EBV.
Okay.
And yeah, they list those key symptoms straight away.
Mm-hmm.
The fever, the really sore throat, those swollen lymph nodes, often the ones in your neck, are quite noticeable fatigue and that general, feeling unwell, the malaise.
So that nickname, the kissing disease, the notes actually explain that, right?
They do. They mention transmission methods. And yeah, top of the list is bodily fluid secretions, like saliva from kissing.
Okay, so it's not just a myth.
No, not at all. But interestingly, they also make sure to list blood transfusion and sexual contact as other possible routes.
Mm,
So yeah, the kissing thing is real, a primary way it spreads via saliva.
got it. Direct from the notes.
Exactly. And the notes add a bit more precision too. They use this term mononucleosis syndrome.
Oh, what's that distinction?
Well, it's used more broadly. It describes that same pattern of symptoms: fever, sore throat, swollen nodes, fatigue. But when they're caused by other viruses, not just EBV.
Okay.
So if someone looks like they have mono, but the EBV tests are negative,
Hmm.
they might still have this mononucleosis syndrome caused by something else, like CMV, perhaps.
Yeah.
That's actually a really important distinction for revision.
Yeah, that's a key takeaway. So focusing on the main culprit then, the etiology, the notes say EBV.
Right. The etiology section confirms Epstein-Barr virus.
Uh-huh.
And it specifically points out it's a type of herpes virus,
Mm-hmm.
which is, useful context.
Mm-hmm.
And it just reiterates the transmission routes we mentioned. Saliva is the big one, hence the kissing disease idea, but also close contact, generally sharing cups or utensils, maybe even airborne droplets are mentioned as possibilities in the notes.
So pretty easy to pass around in close quarters. Who, based on these notes, is most likely to get the symptomatic version? Let's talk risk factors.
Okay, risk factors. The notes highlight a few key things. Unsurprisingly, number one is close contact with someone who's infected, kissing, sharing drinks, that sort of thing.
Makes sense.
Having a weakened immune system is also listed, makes you more susceptible. But a really high-yield detail for you to remember is the demographic peak.
Okay.
The notes are quite clear. Adolescents and young adults are the group most likely to develop symptomatic mono. This gets pinned down later in the epidemiology bit as the 15 to 24 age group.
Right. The classic age for it.
Exactly. And there's also a quick mention that certain genetic factors might increase the risk of getting severe symptoms, which is interesting. Suggests a bit of a host genetic role in how bad it gets.
Okay, so age and close contact are big ones, especially for actually feeling sick from it. So how does this herpes virus, actually cause all these problems? What's the pathophysiology according to the notes?
Right. This part gets down to the nitty-gritty, the cellular level. The notes explain that EBV primarily infects and then starts replicating inside B lymphocytes.
Okay, the B cells in the immune system.
Exactly. They're a type of white blood cell, really important for making antibodies. But here's the key bit that explains the symptoms. Your body sees these infected B cells and launches this massive immune counterattack.
Right.
This triggers the activation and a huge proliferation, like an explosion of another type of immune cell, the cytotoxic T cells. These are the killer T cells. Their job is to find and destroy infected cells. So it's this really intense battle between your own cytotoxic T cells and the EBV-infected B cells that causes widespread inflammation and kind of stirs up other immune cells all over your body.
So the symptoms are actually the fight.
Largely, yes.
Yeah.
That immune system reaction is what leads to the fever, the sore throat, the swollen lymph nodes that you actually feel. It's not just the virus directly causing damage. It's mostly your body fighting back really hard.
Wow, that really clarifies the link. The immune response is a huge part of the illness itself. Okay, shifting gears a bit. Let's look at the bigger picture. Epidemiology. Who gets this? Where? When, according to these notes?
Well, the notes admit that the exact prevalence, like how many people have it at any one time, isn't perfectly documented,
Okay.
but they give some crucial context, especially from a UK standpoint. They state that the majority of people in the UK actually get infected with EBV much earlier, often in childhood or early adolescence.
Oh, really?
Yeah, and often that childhood infection is totally asymptomatic or maybe just seems like a mild cold. You wouldn't even know it was EBV.
Right.
But then, tying back to the risk factors, the notes confirm that the peak incidence of actually getting sick with symptomatic infectious mononucleosis happens later, specifically in that 15 to 24 age group.
So you catch it young, maybe don't notice, but it waits till you're a teen or young adult to cause trouble.
That seems to be the pattern highlighted.
Yeah.
Geographically, the notes mention it's generally more common in developed countries, but you find it pretty much worldwide.
So most of us meet the virus early on, but it tends to cause that classic mono illness later for young adults. That connects epidemiology back to the age risk nicely. Okay, let's move from stats and cells to the patient. What does it actually look like? The clinical presentation.
Yeah, the notes are pretty detailed here on signs and symptoms. The classic triad is there again. Fever, sore throat, and those swollen lymph nodes, particularly neck and armpits.
Mm-hmm.
Beyond that, they really emphasize significant fatigue and malaise, feeling generally unwell as being almost universal.
That exhaustion people talk about.
Exactly. And specific to the throat, they mentioned enlarged tonsils. And here's a high-yield detail for your revision. Look for possible white patches on those enlarged tonsils.
Ah, okay. White patches.
Yeah. Other symptoms listed include headache, sometimes a rash, abdominal pain, muscle aches. Jaundice, that yellowing of the skin or eyes, is also mentioned as possible in some cases if the liver's involved.
Right.
And crucially, the notes highlight the duration. These symptoms aren't just a few days. They can drag on for weeks, even months. That explains that persistent fatigue.
Weeks to months.
Yeah.
Yeah, that sounds really debilitating. What about things a doctor might find on examination? Physical signs.
Okay, physical signs listed in the notes. Hepatosplenomegaly, that's the medical term for an enlarged liver and spleen.
Right. Both.
Both. Jaundice can be a physical sign, as we said. They mention a maculopapular rash. That's a rash with both flat spots and raised bumps. Palatal petechiae are listed two tiny little red or purple spots on the roof of the mouth.
Oh, interesting.
Yeah. Bruising can sometimes occur. And periorbital edema, which is swelling around the eyes.
Swelling around the eyes.
And a really vital point the notes make for revision, most cases in young children are asymptomatic. So the presentation is very different compared to adolescents.
That's important.
Definitely. And finally, they highlight a severe, potentially dangerous presentation, upper airway obstruction. This can happen if those tonsils and the lymph nodes in the throat get so swollen, they actually block breathing.
That sounds genuinely scary. Okay, with all these symptoms and signs and some overlap with other illnesses, how do you actually confirm it is mono? The notes must cover differential diagnosis. What else could it be?
Absolutely critical section for revision. The notes list several conditions that can look very similar. Top of the list is streptococcal pharyngitis, common strep throat.
Right.
Also general tonsillitis from other causes, and other viral infections that cause a similar picture, specifically naming cytomegalovirus, CMV, as a key one to consider in that mononucleosis syndrome category we talked about.
Okay, so strep, tonsillitis, CMV.
Yeah, those are key ones. And the notes really stress. You often can't tell these apart just by looking at the symptoms. You absolutely need a thorough medical history, a physical exam, and lab tests to figure out what's truly going on.
Right, the lab tests become crucial then.
Exactly. Which raises the question, what investigations do the notes say we should use?
Yes, let's dive into the labs. How do the notes say we investigate suspected mono?
Okay, so the notes state that while the diagnosis often starts with the overall clinical picture, the history and the exam findings lab tests are pretty essential for confirmation and ruling out those differentials. The tests listed include a full blood count, or FBC. The notes say this might show an increase in certain white blood cells, often lymphocytes, and potentially some other things like myelonemia or thrombocytopenia, which is a low platelet count.
Okay, low platelets possible.
Possible, yeah. Then there's the test you've probably heard of, the monospot test.
Ah, yes, the monospot.
This looks for something called heterophile antibodies. These are a specific type of antibody your body often makes during an acute EBV infection. And the notes say the monospot test is typically positive in infectious mononucleosis, especially in adolescents and adults.
So a positive monospot is a strong clue.
Yes. According to the notes, that's a very common finding in symptomatic mono in that typical age group. But they also mention serological tests.
Okay, what are those?
These are more specific antibody tests. They look directly for antibodies against the EBV virus itself, things like anti-EBV IgM and anti-EBV IgG antibodies.
Ah, more specific.
Exactly. And these are really helpful because they can not only confirm the diagnosis, but also help figure out if the infection is acute, like happening right now, or if it was a past infection. It depends on which antibodies are present. They measure these in the serum, the blood.
Got it. Acute versus past infection. Useful.
Very useful. And finally, the notes mention imaging, specifically an abdominal ultrasound or maybe a CT scan of the abdomen. But they strongly emphasize this should only be considered if there's a real suspicion of a serious complication, particularly splenic rupture. It's definitely not a routine test just for diagnosis.
That's a key distinction. Imaging only if you suspect a complication like the spleen rupturing. Okay, so once you've got the diagnosis confirmed, how do the notes say we manage infectious mononucleosis? What's the treatment?
Right, management. The notes describe the approach, particularly citing the UK context, as primarily supportive treatment.
Supportive.
Meaning, there's generally no specific antiviral medication recommended as standard for typical, uncomplicated mono. The key supportive measures listed are pretty straightforward, but they're crucial. Plenty of rest, staying well hydrated, and using simple over-the-counter pain relief like paracetamol or acetaminophen to help with the fever and the sore throat.
So basically managing the symptoms and letting your body fight the virus off.
Pretty much, yeah. Because it's viral and usually self-limiting, supportive care is the main thing. Now, a critically important piece of advice highlighted in the notes, and definitely high yield for you, is about avoiding activities that could cause that enlarged spleen to rupture.
Ah, linking back to the splenomegaly.
Exactly. The notes are also very clear that antibiotics are useless against viruses like EBV. They should only be prescribed if there's a confirmed secondary bacterial infection happening at the same time, like a bacterial tonsillitis on top of the mono.
Okay, no antibiotics unless there's bacteria involved too. Are there any exceptions? Any specific treatments mentioned for certain situations?
Yes, the notes do list a couple of specific scenarios. For those really severe cases with upper airway obstruction where the tonsils are so swollen they block breathing, corticosteroids might be considered to help reduce that swelling quickly.
Okay, steroids for airway issues.
Potentially, yeah. And in very rare cases where mono causes severe thrombocytopenia, that low platelet count we mentioned, and the person has active bleeding because of it, then IV immunoglobulin therapy, IVIG, might be used. But these are really exceptions for specific severe complications.
Got it.
Going back to the activity restriction, though, the notes really hammer this home. Avoid contact sports or any kind of strenuous exercise for up to 8 weeks, specifically to prevent that dreaded splenic rupture.
8 weeks. Wow, that's a long time.
It is. They call it a key practical point, and it's definitely memorable for revision 8 weeks off sports. And generally, hospitalization isn't needed. The notes state it's usually self-limiting.
That 8-week rule is a big one, definitely sticks in the mind. Okay, so summing up management, mostly supportive, rest, fluids, pain relief, watch out for specific severe issues, and that major activity restriction. What about the long-term outlook? Prognosis.
The notes give a generally good prognosis overall. Most people do recover fully, although it takes time, typically weeks to months.
Okay, good news mostly.
Mostly, yeah. However, they do make a point that the fatigue and weakness can definitely linger for quite a while after the main acute illness is gone. That's that post-viral fatigue picture many people describe.
Right, the lingering exhaustion.
Exactly. And while the outlook is good for most, the notes do reiterate that rare but serious complications are possible. They list splenic rupture again, hepatitis, and neurological problems. Full recovery, they state, really requires proper rest and self-care.
That lingering fatigue certainly explains why people can feel off for so long afterwards. You mentioned serious complications are possible, even if rare. What specific potential problems are listed in these notes?
Okay, complications. The notes detail several, stressing they're uncommon but can be serious. Splenic rupture is highlighted yet again, and they specifically note it's more common in adolescents, another reason that 8-week activity restriction is so vital.
Right, keep hammering that point.
Other acute complications listed include hepatitis and jaundice related to liver inflammation, myocarditis, which is inflammation of the heart muscle, and certain neurological issues like Guillain-Barré syndrome, GBS, which affects the nerves, and meningitis, inflammation around the brain and spinal cord. The notes explicitly say that following the medical advice, especially on activity, is crucial to prevent these.
Okay. And the notes also had that section on additional complications, which sounded quite significant.
Yes, this section lists complications that are often more like long-term associations, and these are definitely important points to remember for revision. This is where the link between EBV and certain types of cancer is mentioned.
Cancers. Really?
Yes, the specific types listed are nasopharyngeal carcinoma, Burkitt's lymphoma, other lymphoproliferative disorders, and Hodgkin's lymphoma. Now, these are rare outcomes of EBV infection overall, but the virus is known to be associated, and the notes make sure to include them as potential long-term complications. Other things listed in this additional section are interstitial nephritis, which is a kidney problem, and encephalitis, which is inflammation of the brain itself.
Okay, that list of potential long-term issues, especially the connection to certain cancers, however rare, is definitely not what most people think of with the kissing disease. It really puts the virus in a different light. So, connecting all this detail back, why is knowing this whole spectrum from the common sore throat to these rare but serious possibilities so important for revision?
Exactly. The relevance, drawing from these notes, is about having that complete picture for your revision. It's not enough just to know the classic symptoms. You need to grasp how it spreads, who's most at risk for getting really sick, the basic mechanism, how the immune fight causes the symptoms. You need to know the key diagnostic tests, especially monospot, and the specific EBV antibodies, the mainly supportive management, that absolutely crucial activity restriction, and importantly, the full range of potential complications, both the immediate ones like splenic rupture and these rarer but significant long-term associations like the malignancies.
Right.
And knowing the differentials helps you rule out other things. All this detail, from common to rare, is vital for recognizing mono, understanding its potential path, advising patients correctly, especially about activity, and knowing when things might be more serious and need closer attention. It's about getting that truly high-yield understanding.
Yeah, it's about being properly informed, going way beyond the catchy nickname to understand the virus, its real impact, what to look for, covering all the points these notes lay out for you.
Absolutely. And maybe just to leave you with one final thought, something to mull over, that arises from these notes. Given that most people apparently get infected with EBV by the time they're adolescents, yet the peak time for actually getting symptomatic mono is specifically that 15 to 24 age bracket, and young kids often have no symptoms at all. What does that age difference in presentation suggest? What might it tell us about the interplay between how mature our immune system is and how this specific virus expresses itself?
Huh? That's a really interesting point to think about after going through all the details, how our bodies handle the same virus differently as we grow up.
Indeed. Something to consider.
Well, that wraps up our deep dive into these revision notes on infectious mononucleosis. We really hope this conversation has helped you pull out the key high-yield information straight from the source material for your revision.
Hope it was useful.
Thank you for joining us on this deep dive.
Thank you.
We'll see you in the next one.